Hello, I welcome you all to TrueNat Hybrid Training for LTs in NTP Andaman Nicobar Islands, Part 3. I'm Dr. Keerthivasan, microbiologist from Intermediate Reference Laboratory, Port Blair. In Part 1 and 2, we saw about various principles of PCR, how a TrueNat machine works, what are the components of TrueNat machines, what are its ingredients, reagents, kits which are required, how to process a sample in TrueNat. Then we saw what are the different ways we can troubleshoot in case there is any error during DNA extraction or PCR amplification. We also saw the different steps which we have to take for maintenance of these instruments. So today in part 3, we will be discussing about other topics like turnaround time, external quality assurance, standard operating protocols which have to be displayed in a TrueNat site, records to be maintained. Once you have done the test, how you go about doing Ni-Kshay entry and post-test. So coming to turnaround time, so as we are progressing more and more towards TB elimination, all the services which are given through National TB Elimination Program, there are certain quality indicators for it. In the sense that when a test is given for a particular patient who is a TB suspect, how long does it take for him to get the result? So it is broadly divided into three parts. That is pre-lab turnaround time before it reaches the lab, the sample, that is pre-lab turnaround time. Then lab turnaround time, once the sample reaches the lab till the reporting of results. Then post-lab turnaround time. So once the result is reported, the result goes to the clinician and appropriate treatment, initiation or modification is done. So the basic idea is so that we decrease the duration of this entire all three components so that the patient can get the correct results as soon as possible and he is put on appropriate treatment for TB. The turnaround time for NAT, that is for TrueNat and Gene Expert. So pre-lab turnaround time is considered around 1 to 2 days. Lab turnaround time is considered 1 to 2 days, and post-lab again in 2 to 3 days. Okay, so the total turnaround time for a NAT test from patient identification till treatment modification or initiation is around 4 to 7 days. So we mostly will stress on this particular component, that is lab turnaround time. So when you get the sample in your NAT site, TrueNat site, so within 1 day, same day or the next day, the result has to be ready and uploaded or intimated to the consent. Now coming to external quality assurance, so you're already aware that we have a very robust program for external quality assurance for sputum microscopy. So similarly, there is new initiative for these NAT site and NAT tests also. So here also we have one on-site evaluation of TrueNat site. There is a format for that. We'll discuss that. And there is also panel test. Like we have slides, 5 slide panel test. So there is also panel test. Currently, it is mainly done for Gene Expert and it is conducted by our National Tuberculosis Institute in Bangalore. So from there, they send 5 dry test tube samples. So it is reconstituted using sample reagent, and after that, the 5 samples are run, and the tests are again matched with all the other centers in India and also with the base reference results from NTI. And we get a score out of 100. So till now, we have been doing quite well in this EQA for Gene Expert. Soon it will be expanded to TrueNat also. Now, whenever there's a lab component, most of us think that it is mainly the LT or the microbiologist or the laboratory supervisor who is involved. But lab is a very integral part of our TB program. It impacts the treatment initiation, and also if there is during treatment, if there is any treatment modification has to be done. So all these are affected by lab results. So it is very important that all the stakeholders participate in this particular activity of supervision in NAT site. So here you can see a senior treatment supervisor, he has to visit at least once a week so that he knows what are the new cases which are reported. And STLs, they have to at least visit once a fortnight so that they can supply with the necessary reagents and consumables. Senior DRTB TB HIV supervisor, okay, at least once a month they have to visit. And also the other higher level officials like district TB officer and MODTC, MOTU, so they also can visit once a month. Okay, so that to see that things are going on properly, the lab entry is proper, Ni-Kshay entry is proper. State officials during IRL visits, they'll see a sample of TB detection centers, and along with they'll visit some NAT centers. Other than this, you are obviously aware that our National Reference Laboratory also visits our islands once in a year, and they'll also be visiting a handful of NAT sites. Now let's see what is TrueNat on-site evaluation form. So here is an example of TrueNat on-site evaluation report. So here we can use for multiple sites. So here you can see site 1, site 2 and site 3. Or also if you are doing for only single site, you can combine this and write the site name. Okay. So before you start the checklist, there are other parameters which are taken into account. For example, various factors which are involved in sample collection and transportation. So before we do a checklist of the TrueNat site, so that site we should also check whether the samples do they reach properly on time, or if or are there enough quantity of sample transportation materials, and how many number of samples comes through a NAT site. Okay, so all this have to be examined before we start this checklist. So first equipment. So obviously, how many number of TrueNat machines are there? What is the type of TrueNat machine? Do we have single module, dual module, or quattro four module? When was the machine installed, and is it still functional? Okay. So the adequate amount of space. So some space is required for proper functioning of these different machines. So we have a DNA extraction machine, we have a PCR machine, we have a Bluetooth printer. So is it put on a flat, stable surface, vibration-free surface, or is it away from instruments which cause electromagnetic interference? Sample processing, is it done in a well ventilated area? Okay. Is there adequate space for receiving and processing specimens? Is there available electricity which is adequate for testing, TrueNat testing, and battery charging? Are there at least three available sockets? As we know, the three machines to charge them, three available sockets are present or not? Then we also see, is there any sufficient storage space where we can store the chips and the reagent kits? Okay. So chips, as we already discussed, chips it's better for you to store in the refrigerator, not in the freezer compartment, but inside the refrigerator. Does the laboratory have a refrigerator for storing sputum samples? Or the laboratory has a lockable door and secure windows, because these instruments are costly, so we want to keep them in a locked facility. Manpower, is the technician available, dedicated technician available for performing the test? Is the technician performing the test as per the RNTCP training protocol and guidelines? Has the technician undergone a scheduled training? Okay, retraining every 2 years. There has to be retraining. Then we have is the TrueNat SOP and guidance materials, are they displayed properly? Okay. Then we see all the steps of the sample preparation. So is the sample adequately liquefied before loading into the cartridge? Okay, are the PP available? Are they used properly? How many samples were rejected? Okay, rejected. So it is ideal for you to maintain a rejection criteria. If you are not writing in your own lab register, you should maintain a separate rejection criteria. So you should reject samples which contains blood, food particles, tobacco, pan masala, or it is fully leaked and contaminated, because this won't give appropriate result. And this blood, food particles, all are PCR inhibitors. Okay, so you will get the result as invalid. Then how many drops? 2 drops of liquefaction buffer has to be added to the sputum. Then is it incubated properly and mixed for 10 minutes? Then after that, 0.5 ml of liquefied sputum is transferred to lysis buffer bottle. So these are basically the steps of your sample processing. We have to see when the LT is doing sample processing, that whether he follows the steps properly or not. Okay, so here again the contents of transferred to lysis buffer bottle, or the inserted properly, cartridge is inserted properly, elute is fully transferred. Okay, so all these steps, whether the LT is properly doing or not. And RIF test obviously should be only performed after you get MTB detected status, isn't it? So you should not do this RIF test straight away on any sample. First, in that sample, if you get MTB detected, then only you have to do RIF testing. So equipment maintenance. So you have to keep your equipment space clean. Then in the maintenance, we already saw the maintenance chart logbook. So you have to clean the surface of the device. Okay, so preferably you can do it 70% alcohol, and you should be able to manage any spills in the cartridge holder. So already seen in part 2 how to change if a cartridge holder tray is contaminated. Okay, so the routine maintenance, what are the daily maintenance, weekly maintenance, monthly maintenance? This maintenance logs have to be properly documented. And these pipettes, as we have seen, it has to be replaced every 6 months. And these logs of temperature of the refrigerator and temperature of the room also have to be maintained. We'll see what these logs are. Then recording and reporting. So number of days between specimen collection and result reported. Okay, so specimen collection comes in pre-lab TAT, whereas result reported comes in lab TAT. So number of days between specimen receipt and results reported. So this is the lab TAT and it should be 1 to 2 days. So 1 to 2 days sample receipt and result reported. Then we have number of days between specimen tested and result reported. Then the proper registers, PMDT, CNDST registers are available and maintained or not. Monthly indicators, TrueNat monthly indicators, will be seeing what they are. Are they prepared and sent to higher laboratories? Here it is sent to from NAT center to district TB center, and from there it is compiled and sent to IRL. From IRL it is sent to NRL, and NRL sends it to CTD. Okay. If the site, the TrueNat site, is it mapped in Ni-Kshay, and Ni-Kshay entries, that is the results, are they being entered in Ni-Kshay? Currently, mainly the positive results are being entered. Waste management. Okay, so appropriate disinfectants, are they used? Okay, are they prepared correctly? So we know this 1% hypochlorite. So that has to be prepared daily. Okay, otherwise, if you keep it for long duration, it is just water. It will lose its potency. So that has to be prepared daily. So is the proper disinfectant available? And the plastic waste which are generated, are they disposed properly? So we already discussed biomedical waste management. So according to that, the different categories of waste have to be discarded properly. So whether the plastic waste is dipped in 1% hypochlorite, not only that, for 30 minutes. The contact period is also important, for 30 minutes before disposal. Foot operated bin with the lid is available or not. Okay, so biomedical waste management, is it in place? Then usage and downtime. Okay, so is the TrueNat lab utilized to full capacity? Isn't it? So full capacity here, it means UNO module can do at least 5 tests, Duo can do 10 tests, and Quattro can do 20 tests per day. So that is its capacity. So in a working hour, 8-hour cycle, so these many tests it can do. UNO 5, Duo 10, and Quattro 20. So we see whether it is utilized to full capacity. Then if the machine was not functional, why was it not functional? So there has to be a downtime log. So I'll show a log for that downtime log which has to be maintained. So why was it not functional? Is it due to non-working or non-availability of technician? Is it because the fault of the machine, or is it because of non-availability of technician? Okay, so this log has to be maintained. It is a downtime log. So inventory, what all consumables you get, there has to be inventory for that. At least 1 month stock should be available in a peripheral TrueNat site. Okay, so 1 month stock should be available. Then the current stocks, are they maintained properly? Okay, if there is any like cartridge or chips which are expired, which is present or not, that also you have to check. Then FEFO principle, that is first expiry, first out. So if you have two cartridges, one expiring this month, one expiring next month, so obviously you have to use the one which is expiring this month. So before expiry, you have to use that particular cartridge, first expiry, first out. Then quality control. So quality control, again here we have running positive and negative control every 50 tests. So this actually we are not doing. Here the negative control is basically water. You can use distilled water as sample, and positive control is usually a control which is given by the company, which we are not currently doing. So whether we are replacing the glass slide or not, every 200 tests in a module, this glass slide has to be replaced. In part 2, we already saw how to replace a glass slide. So quality indicators, are they being filled and sent to IRL monthly? So this is about quality. Now quantitative indicators, that is how many were done and what is the problem, the numbers. So number of tests. So say just take a last quarter and see how many number of tests were done. So out of that, how many DNA extraction was unsuccessful? So there is a limit, like it is to be less than 5%. Number proportion of MTB detected. So for example, if you did 20 tests, say for 20 tests last quarter, say you got 5 MTB detected, so you have to write like 5 out of 20. Okay, so like that you have to write. Then how many errors? How many errors were there? And errors also you have to calculate. Okay, so errors and invalid, that has to be less than 5%. Then how many were rifampicin resistant detected? How many rifampicin sensitive were detected? Then EPTB sample, how many were tested? For example, 20. If you 5 were EPTB, so 5 out of 20. So then here you have MTB RIF chips. So number and proportion of specimens with RIF indeterminate. In that also errors are seen. That error also has to be less than 5%. So number and proportion of RIF sensitive cases which were sent for first line and second line LPA. RIF resistant cases which were sent for again second line, first line DST. The score obtained in the previous round of EQA. Okay, so currently TrueNat we have not started, but Gene Expert you can get this previous year's score out of 100, how much that particular site has achieved. The number of referrals from private providers. The name of the contact person to resolve technical issues. So obviously here the contact person you have to write the contact person service engineer from Malbio. So you can contact if there is any thing which you cannot rectify using the troubleshooting steps which we had covered in this particular training. You can contact your senior treatment lab supervisor, you can contact your IRL microbiologist, and also for further assistance, you can straight away contact your Malbio service engineer, so who will help you anytime. Now let's say what all are the standard operating protocols SOPs which have to be displayed in a TrueNat site. Okay. So first SOP for sample processing, which we had already shared in the first two parts of this training. Do's and don'ts in the troubleshooting chart. Then latest PMDT algorithm. The current one is 2021 PMDT algorithm. Disinfectant working solution. Here mainly we use sodium hypochlorite. So 1% sodium hypochlorite. So based upon the concentration which they receive in their TrueNat site, how to make 1% sodium hypochlorite. Then spill management. If there is any spill of specimen or contamination is there, how to go about it. Spill management we will cover in a totally separate lecture and we'll share the protocol with you. So let's see what are the records to be maintained at TrueNat site. The first one obviously is your CNDSD register. That is a lab register. Then we have stock register. So all the consumables which you get for TrueNat, so that has to be maintained in a stock register. Maintenance log, so which we already discussed the maintenance log during part 2 of this training. Room temperature log, I'll show you the format, how to maintain a room temperature log, refrigerator log, machine downtime log. And sample rejection log, if you're not maintaining or writing the rejected samples in your lab register, you can maintain a separate register where you can write the samples which you have rejected as per our rejection protocol. Then monthly indicators. We will see how to prepare a TrueNat monthly indicator. Now let's see lab register. So lab register is very important. Okay, so the details which you fill in the lab register only you can use for statistics calculation, your indicator preparation, everything. So first one, obviously the serial number. So serial number, as you know, all lab register serial number starts from January 1st. So January 1st serial number 1 and it continues till December 31st. Then the next year again serial number starts from 1. So name and address. So this you have to properly write name, address, and obviously you have to include phone number so that we can trace the patient if he is positive. Age, that is sex, male, female, or also we have the third group, the transgender, also should be included. Then age, depending upon the age. So here age is quite important because we'll soon see why. Because you have a category called pediatric presumptive TB suspects. So if you know which age comes under pediatric group, so we'll be discussing that. Then only you can classify them under that particular criteria. District and state, basically the health facility where it is referred from. Date of specimen collection, date of specimen receipt at the lab. So here it is written CVNAT lab because this is the old format which our state TB cell has received from other NAT sites when CBNAT site was launched in Andaman Nicobar Island. So basically, it is NAT lab now, so it is also used for TrueNat. So MDR suspect criteria. So based upon our monthly indicators, so they are broadly again divided into presumptive TB, isn't it? Presumptive TB, presumptive drug-resistant TB, private referrals. Okay, so private referrals. So all that criteria you can write here. And within presumptive TB criteria, also again you have pediatric TB or smear negative, X-ray suggestive. You have contacts of DRTB, okay, or afferent molecular. So based upon which criteria it is, you have to fill this particular area so that it will be easier for you to calculate during monthly indicator preparation. Condition of the specimen, here it is written mucoid, saliva or blood. So here basically they are telling about our sputum sample. So for sputum, you can write the visual appearances mucoid, saliva, or bloody. Or if it is extrapulmonary, write extrapulmonary and the type of sample which you have received. Now the date of testing, then the type of suspect. So here smear positive or smear negative. So like when you send a sample to culture DST lab, so you have to write the NAT results. Similarly, when you get those two samples for NAT lab also, if the smear microscopy is done, the smear microscopy results have to be written in the biological specimen form. Okay, then only it has to be sent to NAT. So if the smear was negative, write smear negative. That has its own category. So that is smear negative and X-ray suggestive. Okay. Then based upon the sample, okay, the specimen A, because only one sample we are testing in the NAT center, isn't it? So if the sample comes as MTB detected, we'll send the second sample to a culture and DST laboratory. So here we have to write MTB detected. So here, unlike Gene Expert, here we are doing with two chips. In Gene Expert, in one cartridge, both the tests are done. So first MTB test is done. So MTB test, you write MTB detected or not detected. If it is invalid, you write invalid. If there is error, you write error. So based upon the troubleshooting, you write the second part also here. For example, say if it is invalid and you have to repeat. So when you repeat, the second result also, if it is not detected, detected or invalid, write in the same place. So that when you count, you will count the number of MTB chips, because in indicator you have to count the number of patients and also the number of tests, the number of chips used. So if one patient you are using two chip, so MTB chips, one was invalid, second one was not detected or detected or invalid, write both the results here itself so that you can calculate the number of MTB chips. Same for RIF also. Okay, RIF chip, if it is resistant detected or resistant not detected or indeterminate or error, so write in this particular area. Then date of reporting of the results. Okay, remarks. So remarks, if there is, say here we had a DNA extraction error, so here we can't, there is no place to write DNA extraction error. If there was DNA extraction error, kindly note in the remark that this particular sample there was DNA extraction error, because in the end of your monthly indicators, you have to denote the number of errors, also the number of times you have repeated error sample. So all those data will be asked. So you have to write all the details in these particular areas. And once you enter this particular data in Ni-Kshay, you can write the Ni-Kshay ID. So this was lab register. So now we have temperature. So TrueNat site, so you know there is a particular range of temperature and humidity which any machine works properly. Especially this is important for Gene Expert, so you know AC has to be there. Whereas TrueNat AC is not compulsory, but it is still ideal for you to have a temperature monitor, a humidity monitor for your room, and you maintain a log. So here you can see month and year. So you can write the month, say for example January. Then you can have 30, 31 spaces. So you can write Jan 1, Jan 2, and then as per your machine, maximum temperature, maximum humidity, minimum humidity, signature of the LT. So this is how the temperature and humidity log of the room is maintained. Then temperature of refrigerator is also important, because you are storing the chips in the refrigerator, and if the refrigerator is not working properly, then your chips may be spoiled. So temperature log of refrigerator is also important. So here the similar temperature monitoring machine which we're using for room temperature can be used, and that monitor, that end has to be kept inside the refrigerator and the display will be outside. So here also you can write in a similar fashion. month, then dates, then maximum temperature, minimum temperature, signature of LT. Okay. Then machine downtime log. Okay, so this we were discussing. Machine, if is it not working, it is not working due to what reason? Say for example, machine downtime log. So event one, like in January, event one start date started from January 10 till January 20. Okay, so duration 5 days. Reason because LT was not there, LT was absent, LT was on leave. Or say another event is there starting from February 10 to February 25, so 15 days. Reason consumable shortage, consumable was not there, or there was error in the cartridge extraction machine. So basically, all the events related to the machine have to be noted down. If it is not working, we should know the number of days it was not working and what is the reason, so that we can prevent certain things which can be prevented and have optimum utilization of these machines. Let's see some newer definitions. So the current PMDT guideline is 2021. So you have to see certain newer definitions which have changed over the last few years, which will help in writing these monthly indicators and also your lab register. So here you have active case finding. So active case finding is programmatically systematic screening of TB disease through outreach activities. So in the field, you are going and searching based upon symptoms. So that is called active case finding. And if the patient is coming to OPD health facility, it is called passive screening. Okay. As per our program, so adult person is a person over age of 19, 19 and above. Okay, so that is called adult. So child, pediatric. So pediatric, so you may be thinking pediatrics only less than 14 or something, but for the program NTP, child is a person up to including 18 years, 18 years and below. Okay, so that is why when I said that when you're writing the age in the TB lab register, say if he is 17, so he'll be still included in the pediatric age group. Okay, so the statistics of that particular patient will come in pediatric. So child here for our program we use 18 and below, so 18 including. Okay, at risk group. So people who in whom the prevalence of incidence of TB is significantly higher than general population. So people who are more vulnerable. So already you know these things like people who use tobacco, who are contacts of TB patients, okay, who are working in close places, who are living in unhygienic environment like slums. So all these people, including pregnant ladies and even lactating mothers, are at a higher risk of getting TB. Now, who are contacts? Contacts are people who are exposed to people with active TB. Now, who are XDR patients, extensively drug-resistant TB patients? So this definition has changed. So before it used to be MDR TB patient who is also resistant to fluoroquinolones and second line injectable drugs like of the aminoglycoside group. So as the aminoglycoside group is slowly removed from our treatment regimens, though so the definition of XDR TB has also changed. So the current definition of XDR TB is TB which is caused by Mycobacterium tuberculosis, which fulfills the definition of MDR TB. That is, it is resistant to isoniazid and rifampicin, and also resistant to any fluoroquinolone. Okay, any fluoroquinolone. So currently we are using moxi and levofloxacin for fluoroquinolones, and at least one additional drug from group A. Okay, so here second line injectable used to be there. So instead of that, we have put at least one additional drug from group A. So currently in group A, we are using bedaquiline or linezolid. Okay, so either resistant to bedaquiline, linezolid, or both. So that is the definition of XDR-TB. So household contacts, so obviously the people who share the same living space with the TB patients, so those are household contacts. Infants, children under 1 year of age are called infants. Okay, so MDR TB is a TB patient who is resistant to both isoniazid and rifampicin, okay, with or without resistant to other first line drugs. So isoniazid and rifampicin both are resistant, so they are MDR TB patients. The important thing which we see here, form filling and also our indicator formation, so that is presumptive TB examination. So presumptive TB examination, presumptive DRTB. Presumptive TB is any person with any signs and symptoms of suggestive of TB. So isn't it? So we use our 4S screening. Okay, 4 symptom screening, that is fever, cough, weight loss, night sweats for more than 2 weeks duration. So all those people who have any signs and symptoms which fits that criteria will be called presumptive TB suspects. Okay. So this also includes other TB cases like extrapulmonary TB, PLHIV, person living with HIV, children's smear negative and X-ray suggestive cases, and other vulnerable groups like our people working in mines, refugees, people living in slums, pregnant ladies, lactating mothers. So all of them are vulnerable groups. So all of them come under presumptive TB suspects. And slowly we are moving towards NAT upfront testing. That is, if there is any signs and symptom, instead of doing smear microscopy and then coming to NAT, so we are moving towards upfront NAT where the suspect is offered NAT test in the beginning itself. And as you know, it is much more sensitive compared to microscopy. Now, presumptive DRTB. Who are presumptive DRTB? So here refers to patient who is eligible for rifampicin resistant screening at the time of diagnosis or during the course of treatment. Okay, so we know during the course of treatment, if it is a drug sensitive regimen, if he is not responding, a drug sensitive regimen who is not responding, that time also we do NAT. And also H monopoly means he was rifampicin sensitive, but first line LPA isoniazide was resistant, so he is under H monopoly DRTB regimen. So these patients, if there is clinical deterioration during their treatment, that time also again rifampicin status is seen, rechecked again. So all those people come under presumptive DRTB. So this includes all notified TB patients, follow up positive on microscopy, and people who are under treatment of first line regimen and also H monopoly regimen and are clinical non-responders. So all of them come under presumptive DRTB. Now let's take a look at the various lab registers and logs which have to be maintained. So for the purpose of capturing the monthly indicator, so when you write the patient information from the biological specimen form to your lab register, that time itself, if you keep in mind the various categories of monthly indicator and write those information, then it will be easier for you to capture the monthly indicator at the end of the month. So if the sample which has been sent is part of ACF, so inform the health visitors and all the other staff who carry out ACF to mention on the top of the biological form ACF. Okay, so when ACF is written, so you can write this particular part in the category of MDR criteria. So you can write presumptive TB ACF. So that it will be useful for you to calculate that particular criteria in monthly indicators. Then also pulmonary TB based upon the specimen sputum, it is pulmonary TB, extrapulmonary TB, the other specimens, even pleural fluid comes under extrapulmonary TB. Person living with HIV, so PLHIV patients, pediatric. So as I told you, anybody who is 18 and below, okay, age 18 and below, so all of them come under pediatric. You have to count them under pediatric. Contacts of TB or DRTB. Okay, so presumptive TB, there's a criteria of contacts of TB and DRTB. So if this particular thing is mentioned in your biological form, you have to note this particular data in your lab register. Upfront molecular test. So upfront molecular test, it comes to all the patients who are given straight away molecular test instead of first doing sputum microscopy, then doing NAT test. So here straight away molecular test is being offered, upfront molecular test. And not only that, there is a small confusion which was clarified by CTD. So also the patients who were smear positive and after that they are done NAT test is also included in this particular area. There used to be another criteria in monthly indicators called other presumptive. Okay, other presumptive TB. So that criteria is not there. So here, this is where we used to include the patients who used to come to the OPD and were smear positive. Then once they were smear positive, they were given NAT. So this used to be the chunk of the patients. Okay. So but this category is no more there. So even this category is included in upfront molecular test. So soon within a span of next 5 to 6 years, upfront molecular test will be the thing, isn't it? So there won't be any microscopy test for routine screening. So molecular test will be given upfront. You also have to note down the errors, the number of errors and the types of errors, errors in PCR or errors in DNA extraction. As we saw in our on-site evaluation form, there is criteria. Most of the things have to be kept below 5%. If there is it is above 5%, then we have to do additional troubleshooting. Either the LT is not trained properly, or there is some steps which is going wrong and we are overlooking. So we have to keep these errors below 5%. Okay, so these are also have to be noted down in your lab register, and preferably in the monthly indicator in the remarks section. In the remarks section, you can write about the type. So in RIF, invalid, indeterminate. So the number of repeat tests for these have to be also mentioned. Now coming to stock register you can maintain the same uniform stock register for both smear microscopy and NAT center. Both the centers are there at the same place. Here obviously you have to record the number of cartridges and chips which you receive, and you have to, when you receive, you have to note down the lot number, expiry date also, so that you use the first expiry things first, and the later expiry things are used later. Okay, so you have to properly manage the stock, and always you have to maintain a stock of at least 1 month in the TrueNat center. Now let's see TrueNat monthly indicator. How does it look? So here is an example of TrueNat monthly indicator. This is from RPH Hospital Mayabandar. So here you can see the month, the year 2022, and here months you can see here. They are January, February months are written down. So first one is the name of the TrueNat facility. So where is it? Is it a primary health center, CHC, or a district hospital? So here we have Dr. RP's Hospital, Mayavandar District Hospital. Complete mailing address with PIN code. So mailing address with PIN code has to be written. And is the site private or public? So public. And then the other details, district block, contact details with email ID, usually of the concerned medical officer. Here, district TB officer, Dr. Palit's name is here. Then the type of your machine, it is Uno or Duo, and number of machines, and then the serial number of machines. So it is good that if you note down the serial number of both the PCR machine and the extraction machine, because sometimes these things get exchanged with another center. So write down both the serial number, date of installation, and date of calibration. So then after that you have various indicators, quantitative indicators. So here first you have MTB test performed. So MTB test performed is total MTB chips used. Okay, so total number of MTB chips used. So MTB test when you do, you can get not detected, you can get MTB detected, or you can get invalid, or you can get error. So we know this invalid test or error test comes, we have to repeat, and that result can also be invalid, or it can be error, or it can be not detected or detected. So whatever MTB test chips you use and whatever result comes even in repeat, you have to mention here. So then only this 1A, 1B, 1C, 1D, if you add, you should get the total number of MTB tests performed. So this is how you can minus this from the stock of the last month's MTB test chips, and you can find the current stock which is available. Okay. Then we have a RIF test. RIF test again, they also have again bifurcations like 2A, 2B, 2C, 2D. So 2A here, RIF resistant not detected. Then we have RIF resistant detected, RIF indeterminate, and RIF error. So here also this indeterminate and error are again repeated, and so all those results have to be reflected here. Then only 2A plus B plus C plus D will equal to 2. Okay. So RIF chip also have to be accounted. So please remember this number of chips tests which are used and number of patient, it is different. See, for example, one particular patient, one MTB chip will be used and a RIF chip will be used if everything goes normal and if MTB is detected. And there is a possible that MTB is not detected, then RIF chip is not used. And in one patient, MTB may first come error, and second time it may give MTB detected, then RIF chip. So here the number of chips and the number of patient does not match. So please don't worry about that. First worry about MTB chips, then worry about RIF chips. So in serial number 1 and 2, you have to worry only about these things. Then we have public sector and private sector referral. So public sector referral, again number 5 and number 6, this are easy. For pulmonary specimens, how many pulmonary specimens came, how many EP samples came. And private sector, again, how many pulmonary samples were received and how many EP samples were received. In public sector, this number 3 and 4 bifurcation again is there of presumptive TB and presumptive DRTB. So when you got the sample in the form, if it was presumptive TB written right here and presumptive DRTB to right here. Both this presumptive TB, presumptive DRTB have the another set of divisions. So presumptive TB, you also have to see whether it was PLHIV, the patient, or pediatric patient, that is 18 and below age. Smear negative means you got the NAT sample for NAT, but it was smear negative and X-ray was positive, will come here. ACF group will come here, other vulnerable groups, ACF group will come here. Contacts of DRTB, if it is written in the specimen, you have to write here. If it is a EPTB, you have to write here, and molecular, upfront molecular test offered, you have to write here. So presumptive TB, you have to keep in note and you have to write in the lab register itself, it's a presumptive TB. Is it PLHIV, is it pediatric, it is smear negative, or if it is ACF, or if it is contact, EPTB, and if none of these criteria is followed, just write upfront molecular, okay, upfront molecular test. So if it is not PLHIV, if it is not pediatric, not smear negative, not ACF, not contact, not EPTB, put it under upfront molecular test offered, okay, so that you don't have any confusion. Then presumptive DRTB, again we have notified TB patient, okay, so here we have notified TB patient. But the problem here is in Andaman at present, most of the time we do the rifampicin test and only notify the patient. So we do both the tests, MTB and rifampicin, then only notify the patient. If, say, for example, in some remote island, smear microscopy was positive and the patient was notified and was put on treatment, and then the sample was sent here for a NAT test in a NAT center, that time that sample will come under presumptive DRTB. Okay, so notified TB patient and coming for UDST, presumptive DRTB, and also previously treated. Okay, previously treated also comes under presumptive DRTB. Non-responders, clinical non-responders of your DSTB regimen and H monopoly regimen also come under presumptive DRTB. Then we have private sector, pulmonary and EPTB. Here we don't have bifurcation for presumptive TB and presumptive DRTB. So private sector mainly it is bifurcated based upon the sample, pulmonary sample or EPTB sample. So further down you can see here 57 number of errors during DNA extraction. So if there was any error during DNA extraction, kindly note the remarks column of your register so that you can count and write here. The number of repeat tests in TB chip when you are doing, if you got invalid or error, that is 1C and 1D, how many samples did you repeat? Okay, if it was invalid, you have to repeat how many times did you repeat, and if when you repeated, if you got MTB detected, out of that, how many you got MTB detected. Similarly, again 60 and 61, it is rifampicin test resistance indeterminate and error, how many were there, and out of that when you repeated, how many you got rifampicin resistant detected. Okay, so then the samples which you have sent for LPA, okay, 2A and 2B, then after that 63, 64 and 65 are stock, your cartridge stock, okay, extraction cartridge stock, and your MTB chip stock and ref chip stock. Okay? So like this you have to compile your TrueNat monthly indicator at the end of the month. And in the remarks column, please write the type of error, MTB chip, the type of error you got, 1, 2 or whatever. So that type of error you write so that we can troubleshoot later. And when we do error analysis, we can see that what is the real problem and we can troubleshoot properly. Now coming to Ni-Kshay entry. Now you have done the test properly and the test result has to be updated in Ni-Kshay. So Ni-Kshay app is available in Play Store. So you can go to Android Play Store. If you have an Android smartphone and type Ni-Kshay, then you will find this app. So you can install this app. So once you install this app, you will be asked about login details. So if you have a PHA ID for your TrueNat site, you can enter so that you can enter these lab results. So here there is an example of Ni-Kshay ID which is generated for this particular patient, and now we have done the NAT test. Okay, so how to enter the NAT result. So if the Ni-Kshay ID is already present, just go and search the particular Ni-Kshay ID, and once you get the Ni-Kshay ID, just scroll down. So here you can see test. So we have to add the test results. So obviously click on the tests. And already there is ZN microscopy result which is present. So down you can see one plus button. So that is for add test. So here we will be asked about a reason for testing. So that is your presumptive TB and etc. reason for testing and test type. Okay. So reason for testing: diagnosis of TB or diagnosis of DRTB, follow-up of TB or follow-up of DRTB. So for in this case scenario, we chose diagnosis of TB. Then predominant symptoms you can select as per what is written in the biological form, and whichever criteria it fits at diagnosis or private referral or contacts or a presumptive H monopoly. So all that you can enter here. Then the test type. So test type you can see microscopy ZN, fluorescent, CBNAT. TrueNat, there is you have to do entry two times. CBNAT you will have to do single time entry. But TrueNat you use two chips, MTB chip and MTB RIF chip. So once MTB test is done, that time you have to make a separate entry, and once RIF results are available, that time you have to make a separate entry. So we have done MTB test. So MTB we have selected. So testing lab you can select. So here GB Pant was selected. Then result if it is present. So obviously we are doing this particular activity after result is available. So just press present result available. Okay. So here then you can type the sample sputum. You type click on sputum and appearance of the sputum. It is saliva, mucopurulent blood stain. Then date of specimen collection, date of test. All that has to be selected. If it is EPTB, select other category. Reported by, here it is LT, it is written, the LT can write his own name. So sample 1, okay, so serial number, lab ID, you can give the lab ID, success, then MTB detected or not detected. Okay, so you can write. So MTB again here you can see it comes as detected, not detected, error or invalid. So whichever is your result, you can enter that particular result. Okay, rifampicin here, as you can see, if the rifampicin test is successful, so here you can see it is rifampicin resistant detected or resistant not detected or indeterminate. So whichever criteria you have, so you can enter for that. Okay, so with this we have come to the end of our final part 3 of TrueNat hybrid training. So I'll be sending a link of Google form for post test. So please select the correct options and submit the post test, and you can see your results soon after. The training documents I have attached in your Echo account, so you can go through them. Thank you for being part of this hybrid training for TrueNat. Hope you all benefited from this training. Until we meet next time, thank you.